Welcome to POPMA Study Club, the regular series, 19th April 2025, Saturday, from 3 p.m. onwards. On behalf of the Practicing Oral Pathologists and Microbiologists Association, fondly known as POPMA, I extend a heartfelt welcome to all our esteemed colleagues, students, clinicians, and specialists joining us today for this session of POPMA Study Club, the regular series. POPMA is India's national organization dedicated to advocating, empowering, and advancing the professional role of oral pathologists and microbiologists in both clinical and diagnostic settings. We have different initiatives like the POPMA Gold Medal, the POPMA Research Grant, the Oral Pathologist magazine, and POPMA has remained at the forefront of uplifting our specialty and integrating into the mainstream healthcare. POPMA Study Club is yet another important step in this journey, a platform that fosters collaborative learning across specialties, bridges gaps between diagnosis and treatment, and promotes interdisciplinary synergy. As oral pathologists, our role is not only limited to academics. We are essential partners in accurate diagnosis, prognosis, and treatment planning. Thank you once again for being a part of this vision. Let us keep learning, collaborating, and building the future of oral pathology together. So today we have our special guest for uh, today's session, that is surgical margins in head and neck cancer by Dr. Shelja ma'am. It's an absolute privilege to introduce our distinguished speaker today, Dr. Shelja Chatterjee ma'am. She's an eminent oral and maxillofacial pathologist, academician, and clinician with over 17 years of exemplary service in dental education, research, and clinical excellence. Dr. Chatterjee currently holds the position of Professor and Head, Department of Oral Pathology at Jamna Institute of Dental Sciences and Research, Jamnagar. She is also the President of Indian Dental Association Saharanpur branch and a former Executive Committee member of IOM. Added to her multifaceted professional identity, she serves as the Director of Oral Cancer Screening and Dental Care Center, Saharanpur, where she leads vital initiatives in cancer awareness, community screening, and advanced dental care. A proud alumni of Manipal University, Dr. Shelja ma'am holds both BDS and MDS degrees in oral pathology and further her academic journey by completing a PhD from MMU Mulana, Haryana. Her academic accomplishments are underscored by a remarkable publication record, including 50 research articles, book chapters, monographs, and authored textbooks on genetics and oral physiology. Her work has received over 495 citations, and she has an H index of 9, reflecting the impact and quality of her research in the field of oral oncology, forensic odontology, salivary diagnostics, epigenetics, and molecular pathology. She is a well sought speaker and has been invited to deliver lectures and keynote addresses at various prestigious platforms across the country, including medical colleges, international conferences, and academic symposiums. Her recent talks on cutting edge topics such as artificial intelligence in healthcare, microbiome, mucormycosis, forensic odontology have been highly appreciated by peers and students alike. Her leadership, vision, and commitment to advancing oral pathology and public health make her a role model for the dental fraternity. We are truly honored to have her with us today, and we look forward for gaining from her insights and expertise during this session. Please join me in welcoming Dr. Shalija Chatterjee, ma'am. Welcome, ma'am, and over to you.
Good afternoon to Dr. Bhuvan for that exemplary introduction. I am highly grateful that POPMA has provided me this platform to introduce as well as further the knowledge regarding surgical margins in head and neck carcinoma, as majority of us are oral pathologists, and we, when receiving gross specimens, are expected to give a clear-cut definition to the surgeon and oncologist so that the patient can benefit from that. So very good afternoon on a warm Saturday. I'll be starting with my topic on surgical margins and head and neck cancers. So what is the importance of surgical margins? Next, Bhuvan. Next slide. So, oral squamous cell carcinoma, despite the cutting edge advancement in science and technology, has a significant incidence all around the world. Thereby, it's the major cause of morbidity as well as mortality in patients, especially those who are suffering from head and neck cancers. And currently, the major treatment modalities revolve around surgical excising of the tumor, which is followed by radiation and chemo. That will again be dependent upon what the pathologist reports in the slide. Next, please. Next. So, why is the surgical margin important? An oncologist decide what dosage of radiation and what type of chemotherapy has to be given to the patient depending upon the histological status of the margins. And the status is usually graded in surgical margins depending upon the distance of the tumor tissue from surgical margins into either a negative involvement, a close involvement, or a positive margin. Next. So, what a pathologist should look for? A pathologist primarily should look for dysplastic features within the surrounding epithelium and also look for perineural and vascular invasions. Besides, there are other additional pathologies as well. Next. The malignant tumors of squamous cell carcinoma, especially of the oral cavity, have been found to secrete parathyroid hormone related peptide, which can cause hypercalcemia, which is related to cancer. So, if you do a body analysis of a person of oral squamous carcinoma, you will find high levels of serum calcium and increased angiogenesis, which makes the bioavailable levels of calcium very high, as a result of which sometimes non-specific calcifications can also be observed on the surgical margins in a slide. Next. So these are the few of the accidental pathologies which can be observed as surgical margins. If you have taken a transformation from oral submucous fibrosis, you may file OSMF on the sidelines, leukodema, sometimes retention cysts, calcifications due to heightened body calcium level, mucus extravasation cysts, inflammatory salivary gland tissue, even lichen planus, which can transform sometimes, non-specific giant cell reactions, hemangioma, superbacillus split, which can be artifactual or maybe due to the weakening of the interface, due to the loss of cohesiveness, due to the character of carcinoma. Next. You can even look for totobodies or mucosa-associated mole tissue, lymphangiomas, inflammation of the muscle, chronic non-specific inflammation, and sometimes even ghost cells have been reported by some of the investigators. Next. So these are the slide frames that you are seeing. In picture labeled as A, you can see oral submucous fibrosis, very nicely seen, a suprabasilar split in the next picture, a mucocele, then totobodies on the superficial epithelium, mold tissue, sometimes with the germinal center, non-specific calcification, some inflammation which could be non-specific in nature, ghost cell, foreign body giant cells, even hemangioma. And these can be frequently found in some of the cut margins that you see under a slide microscope. Next. So what are the types of tumor margins? They can be characterized as either clinical margins, which are margins of the tumor one a surgeon sees on clinical observation and palpation, and which are included while resection. Then we have surgical margins, which refers to any tissue plane where the surgeon knife will meet the patient's tissue. Along with the mucosa, at the edge of the tumor, it can also include deeper connective tissue as well as submucosa, which will help in determining the infiltration if there is any. Next. So, what are the controversies when we talk about histological margins? The prognostic risk factors of oral cancers is multitude in number. For example, the staging of the tumor, its grading, histopathological marginal statures, lymph and vascular invasion, perineal spread, or a perinodal spread. Now, although surgeons will always aim at resection with a clear margin, that is the goal of a good surgeon, close margins are always inevitable. And moreover, oral anatomy, as you all know, is very complex because all the intricate structures they lie very close to the tumor tissue. So positive margins can be very frequently observed in oral cancer resection when you compare to cancers which are excised from other sides of the upper aerodigestive tract. Next. So what has been done till now? Frozen sectioning, which is an intraoperative tool, has been able to benefit patient as it identifies involved margin at the time of surgery only and help the surgeon on in the OT to further revise the margin. But that still does not give the close margins. So what is close margin? How far away from the tumor margin do we find the healthy tissue, and which is only possible to be evaluated after a complete evaluation in a histopathological lab, which is not possible in short intraoperative period. So even after you have given a clear frozen section margin, the tissue that has been resected has to be grossed, has to be processed, and has to be reported by a pathologist to look for any further involvement, which will help in revising the surgery or aid in given radiation and chemo as and when the case dictates. Next. So margins can be regarded either as clear when it is more than 5 millimeter. Next, Bhuvan. A close margin is 1 to 5 millimeter distance, and if it is less than 1 millimeter, then it is said to be involved. That is when a surgical repetition has to be done. For the close margins, one opts usually for radiation therapy. Next. So there are some studies which have given a lot of controversies regarding the classification of positive margins based on histology. For example, Loser et al. Have in 1978 have classified margins as per margin closeness if tumor is residing within 0.5 centimeter, if there's a pre-malignant change in the margin, or there's an in situ carcinoma in the margin tissue, or there is invasion with the microscopic center in the margin. Next. Then again, Lorry and Strong in 1990 considered lesion tissue within 0.5 millimeters of surgical margins, with an exception of larynx, a dysplastic epithelium, carcinoma in situ, and invasive carcinoma and margin to be positive. That is a strong change from what was earlier described by Loser et al. Next. So how is surgical margin evaluated? It can be evaluated in 3 steps. First is the preoperative assessment, next is the intraoperative assessment, and third is the postoperative assessment. And in preoperative assessment, vital staining like Toldon blue staining, most of us are aware or can be used. Most recently, fluorescent visualization, I'll be talking about this further on, has been introduced. Intraoperative assessment, when you look clinical thickness of recessed margins, that is personally a surgeon's point of view. Frozen section analysis is only when giving you whether at the time of excising there is any tumor tissue present or not. Post-operative assessment can be done either in terms of Mohs microsurgery, a frozen technique, and formalin, of course, we all are aware of that. Ultrasonography, molecular assessment, and gene signature are recent advances which should be further explored to tell upon the actual positive margins that will benefit a patient's prognosis. Next. So what are the factors affecting the assessment of surgical margins. We all know when we process a tissue, they undergo shrinkage. So, that shrinkage will reduce the dimension of the tissue due to release of tension from the surrounding tissue after it has been surgically released. Next. So, the degree of shrinkage of surgical margins differs from different anatomical sites. These are some authors who have studied the tissues with differentials in shrinkage. So you can see in most of the time, the tissue involving buccal mucosa has been reported to show maximum amount of shrinkage. So whenever you are looking at a tumor tissue or buccal mucosa, maybe even tongue, you can expect that actual close margin to be very less than what you are observing under the microscope. Next. So shrinkage in specimen can vary by location, as we have seen in the previous slide. Intratumoral tissue might be showing little less shrinkage because over there, most of the contractile elements within the cells, they are already destroyed and they have been replaced with non-contractile element containing tumor cells. The margin of the tissue, if tumor is absent or minimal, you are going to see significantly more amount of shrinkage compared to intratumoral margin. The composition of tissue margins may also contribute to variation in shrinkage. For example, if you have a mucocele at the margin, you can expect a large amount of shrinkage over there. Or suppose you're looking at tumor from the skin, for example, basal cell carcinoma. Intratumoral shrinkage is 11% over there, whereas the tumor-free margin is 19% shrinkage. However, if you have staged the squamous cell carcinoma into well differentiated, moderate, and poor, that is not going to influence the shrinkage margin. So basically, the staging is not so much of effect causing the effect rather than from where and how the tissue has been taken. Next. Next, we move to molecular margins. Now, this is what will tell upon the genetic changes in a cell. As we all know, even giving a clear margin under microscope, most of the cases will come back with local recurrence, and the number is pretty high, ranging between 10 to 30%. So these reasons will include if they have minimal residual cancer. Routine histopathology will not detect the minimal residual cancers because they are still residing in the mutated DNA within the borderline cells. And of course, there are field of genetically altered cells that remain macroscopically undetectable. So these fields are actually serving as fertile grounds for evolution of either potentially malignant lesions or they can even develop into invasive cancerous lesions later on. Next. So majority of these altered fields can only be identified if you are doing immunohistochemical analysis or you are looking at genetic analysis. Immunohistochemical expression of markers such as P53 or Ki67 are proven to show the marginal tissue with cancerous involvement. But if you look for loss of heterozygosity by means of PCR, you are even telling upon a greater change at the RNA level. And these are actually the useful prognostic markers which can influence the clinical management further. So all the margins which have been sent to a pathology lab should be tested by means of immunohistochemistry. If constraints are not there, you can even go for PCR analysis. Next. So these are some of the genes or oncogenes and proto-oncogenes which have been reported in tumor tissues, which have been reported cancer-free on routine. But if you put them into further testing, they are all carrying mutations which can result in recurrence as well as what we know as the second primary tumors at the site of primary tumor, calling it a clinical recurrence. Next. So what you know, we know there are a number of studies which show tumor-free surgical margins. You can see here that I have taken this from a journal, which is basically a meta-analysis. It has showing mutations in P53, MMP, Col4A1, even THB52, and variety of molecules which have been tried and tested for their overexpression, which will correlate with the local failure and development of a tumor over there. Even additional molecules like E-cadherin and MMP9 can also be acting as the useful markers. So a panel has to be studied if we look into the actual status of the surgical margins to give a true report. Next. The next advancement is that you can even look for amino acid signatures which are related to the surgical margins. As some of these amino acids, they are expressed in this plastic margins. As you can see, this is a study when they had analyzed using ROC curves. You can see the test power is pretty high for the lesions like your glutamine, aspartic acid, proline, asparagine, and histidine in dysplastic tissue, but negative margin will have other amino acids expressed. You can see there's a uniformly test power is the same, either 0.98 to 0.99 over here. So here, if you're seeing expression of amino acids, leucine, threonine, histidine, lysine, proline, and so on, then you are looking at a probable negative margin. Next. So, what is how an amino acid is studied? So, what you can see, the workflow diagram that is labeled as A, you have selected a particular tissue. So, you have taken that particular sample from there and you have verified the composition of the tissue. And from the same area, you are testing for amino acid racemization. In the picture labeled as B, you can see a tumor which is divided into 4 zones. A tumor zone, an M1 with 0 to 5 millimeter distance from the tumor margin, M2 with 5 to 10 millimeter of tumor margin, and M3 with 10 to 15 millimeter tumor margin. As you can see on the extreme right, T is frank tumor. In M1, there is involvement, a good involvement of tumor tissue. Although it is 0 to 5 mm only. But if you move little further, there are hyperplastic changes, but you cannot see any frank tumor. But of course, when you're seeing some changes like hyperplasia or otherwise, you can expect some changes to going on. So basically, we are discussing metabolic changes in a cell over here. And even the M3, which is further 10 to 15 millimeters, there also you're seeing spongiotic changes. That also suggests that are changes which will be reflected even if we study either gene amplification or by means of amino acid signatures. So this is a diagram. So you can see at the further right, the tumor tissue and the M1 margin that is less than 0.5 millimeter is showing very dark shades ranging from brown to red. All these dark areas are intense expressions of amino acids which are showing surgical margins which have involvement of tumor. But as you move further, the expression will reduce or disappear, looking at a safe margin. Next. Next, please. Next, please. So this is another advancement, that is the EGFR targeted fluorescence molecular imaging for intraoperative margin assessment. It's a phase 2 trial still going on. It has been published in Nature Communications. So in the first picture, we are seeing a carcinoma of tongue. So if you are analyzing that area through in vivo imaging and spectroscopy, you are going to see fluorescent areas intraorally. If the lesion has been excised and you see the whole image specimen imaging, you can have actually a better view of the excised specimen due to its three-dimensional excision. When you look in the oral cavity, you're probably looking at surgical planes, which is too marginal. But if you're looking at a excised specimen, you can have a good view by means of a 3D representation. and it will actually tell upon all the surgical planes which are positive without going in for any extra lab oriented procedures like PCR, immunohistochemistry, or even metabolic. Only thing you have to do is to expose that area to fluorescent molecular imaging that studies the EGFR expression. And if it is positive, it is going to glow, and you're going to clearly tell whether that margin is positive or not to surgeon based upon a simple tool which will come in future handy for all of us. Next. So these are the clinical pictures of tongue carcinomas. You can see in the down picture, there's a large tongue lesion. And when you expose it to fluorescent imaging, the entire area is just shining because of the EGFR mutation. If you're on the other side of the tongue, there is no tumor growth. You are not seeing any mapping over there. So imagine you look at the excised specimen and you just orient it once you get it from the surgeon, and you orient it and you just expose it to the EGFR labeled spectroscopy fluorescence imaging. You are going to see positive involvement of the margins or negative. That is reduces the workload, but also is very useful in times to come. Next. And these are other diagnostic images. You can see a tumor positive area at first in vivo staging, or you can make out there's a tumor. You have excised it, you've done ex vivo, you've done pathology. You can even expose the pathological slide to this fluorescent imaging, and you can even see the tumor shining in there. That's the beauty of this technology. So it's not just working on the vital or tissue, it can even work when the tissue has gone through all the processing and all. You don't have to worry about any genes, any proteins getting deactivated by means of processing or chemical reaction. So as you can see, this advancement will be of a very great use to all pathologists in time to come. And you can even see the closed margins shining, and even tumor negative margins are also shining. So you can see here it is more specific and will help in deciding upon the treatment modality in the patients. Next. So this is my concluding slide. So once you see your resected specimen, all of us are pathologists. The important thing is you have to ink it. Inking is done by means of India ink most of the time. Even people use eosin. It will help you in orienting according to the surgical plane. If you have a resection specimen, you want to give on the spot diagnosis where the surgeon should cut any further, you do frozen section analysis. Otherwise, whatever you received in your lab, you go in for histopath, you look for an involved margin, you either look for a closed margin or you look for a clear margin. In case you have an involved or a closed margin, you go in for molecular and genetic studies that will help you in directing the adjuvant radiation therapies, will help in tailoring the chemotherapy, and even predict the recurrence prognosis as well as survival of the patient to a greater help. If you have a clear margin, microscopically under HNE, you go in for molecular and genetic studies. You identify the altered fields, you identify patients at risk of recurrence, you rehabilitate the treatment alternatives all over again. Like if you have seen large tumor tissue, that surgery has to be revisited. You just cannot just push the person directly under the radiation waves. And then you do a close disease monitoring for such cases. Next. And with that, I end my lecture. I hope that apart from what was already known, I have touched upon some newer aspects as well that will help the postgraduates, the oral pathologists, general pathologists, and whoever is listening to hone their skills in times to come and upgrade themselves so that it will benefit the patient to a large extent and uphold the subject to a great heights as is the goal of POPMA. Thank you. Over
Yes.
to Dr. Bhuvan.
Yes, thank you so much, ma'am, for a wonderful and insightful lecture. And now the podium is open for any questions. You can put the questions in the chat box or you can directly ask. There was a question, ma'am, by Dr. Garima Rawat, that why not do simple histopathology? So, would you like
Okay.
to elaborate on this aspect?
Yeah. Simple histopathology will miss out the genetic mutations, alterations at metabolomics level, and even some extra DNA histone related modifications. So that's why you go in for advanced techniques for diagnosis. We are preventing recurrence in patients. They should not suffer. That's why we must move in for something advanced.
Mm-hmm. No, but her she has also written that the cost is a constraint, which is very true in Indian scenario for this. So anything like you can give any other professional mantras like by which we can uh, like do with the simple histopathology and other things to the practicing oral pathologists. Even availability is also issue. She's writing.
Yeah, but then you have to network with
Yes,
those who are doing it. And when you keep sending samples at large numbers, then probably the cost factor will come down.
correct. Then any more questions? Anybody would like
Dr.
to?
Shailaja, this is Dr.
Yes,
Smita.
Smita.
Ah,
Hi.
yes.
Yes.
Good afternoon, ma'am.
Yeah, good afternoon. It was a very lovely presentation. But
Thank you, Dr. Smita.
routinely, when we get specimens, right, we'll ask the surgeon to give surgical clearance, and
Hmm.
also we'll ask, 1 centimeter clearance, and we check it in the frozen section itself. And
Hmm.
there also one, what to tell, PG will be posted, and they tell yes, the margins are clear, and from
Hmm.
then we take it forward.
Hmm.
So for prognostic markers, what are the things which you are suggesting?
Prognostic immunohistochemically, one can go in for an old man, P53, and then
Mm-hmm.
Chi-67. They can even be done on frozen sections, but then the technique is little
Something
different.
like program cell death related, do you have any marker? They're trying out
Yes,
in Bangalore. Yes.
CL2 is there. You can do backs,
Mm-hmm.
CL2.
Mm-hmm. Mm-hmm. Because some for breast carcinoma and all, they're doing that profiling, right? Similarly,
Uh-huh.
even in ADR cancer and all, they've identified some 18 genes and they're going for a marker analysis.
Yeah, I've
Tumor.
mentioned.
Yeah, that's what the facilities are there. Even in
Yes.
Bangalore, they have started off now in side care and in corporate hospitals. They
Hmm.
do all that, and then only they plan for the reconstruction as well as further
Yeah.
this.
Hmm.
Good presentation. Only thing is, yes, uh, conventionally for the lymph nodes and all, specifically, do you again go in, for skip metastasis and all? Do you check or sentinel lymph nodes in your
Sentinel
hospitals?
lymph nodes. Actually, I was not speaking on that, but then sentinel lymph nodes, if
Mm-hmm.
we have to do, then we should go in for the uh, labeling under the. If you take out these, for example, draining lymph nodes, you put in a
Mm-hmm.
dye and it shines. The surgeon
Mm-hmm.
will give it to you. Then we have
Mm-hmm.
to section the entire node, maybe some 100 sections and on, and every alternate
Mm-hmm.
section has to be stained with the cytokeratin, pan cytokeratin to look for any metastasis over there.
Yes,
That is
yes.
again a very not very cost effective, but then
Mm-hmm.
again it's a useful thing.
Mm-hmm. Okay, because tongue carcinomas are on the rise now.
Tongue and
Uh,
floor of the mouth,
Floor of the
both.
mouth, too much
Hmm.
are on the rise.
Hmm.
So here they insist on, checking for that because bilateral lymph nodes, should they dissect or not, is a dilemma.
Hmm.
Morbidity is too high.
Hmm.
Mm.
Usually in clinical setup, we just palpate. If it is not palpable, we leave it alone. For palpable lesions, we'll do an FNAC and look for any changes.
Okay.
Uh,
Mhm. have you just come across in the literature about methylation kits and all
The
in the
DNA
Western?
methylation is there. Of course,
Oh.
it is there. That is but for histone-related changes. You look
Mm-hmm.
for the cap DNA.
Mm-hmm. Because some Italian groups and all the published papers where for even the prognosis also every 6 months follow up they're checked in for the methylation of the genes. If those are not methylated, then the prognosis is good. That is what they've come out with papers. It's published recently.
That is
Mm.
basically EGFR only, DNA methylation. But then
Uh,
they're going in for the imaging tool now.
yeah,
So,
yeah. Mm.
mhm.
So there are some more comments like amazing presentation, informative presentation, and Dr. Abhishek, are you there? You want to add something to it or?
Yeah,
Nothing,
actually,
Dr. Bo.
Sorry, actually, Dr. Banerjee.
yeah. Hi, Bhadrana sir. Sorry for interrupting you.
Oh,
Actually, I wanted to tell that when actually in the nationwide, what we are like currently following, that is the CAP protocols. And in the CAP protocols, it's just like we have some filling the blanks which we have to address. And there, the prognostic, what Smita ma'am was talking about, the prognostic markers, as per those reports and as per all the cancer hospitals presently, what they are concerned about, whether there is a perineural and perivascular lymphovascular invasion or there or not. So that determines the even the worst pattern of invasion, that is 1 to 5.
Yes,
And one
Abhishek,
more,
it is very much there in my
Yes,
slide.
yes,
yes.
yeah,
Mhm.
ma'am. And one more thing, that is the safe margins, and that is all as per the TNM. But yes, as per the molecular basis, what one more doubt that has come, that whether that Dr. Garima has just pointed out, like what are the other ways and all. Still now we are totally relying in on the histopathology, but yes, even after safe margins, there are recurrences we do get in the labs. That is purely because based on the epigenetic changes, what ma'am was talking about DNA methylation and all. So that as per the present scenario, it is still in the research bed and it is not till in the clinico-pathological. We are not practicing that. That is what I was just telling. And for just like how we are presently going for a routine body test and blood test and all. So there are some hereditary familial gene panel. They have identified a panel of genes that is costing recently for my thesis. I have just inquired about that because I'm doing on mitochondrial DNA mutations. So I just came across it cost around 28 to 51,000, and they will do a gross gene panel that whether there is a mutation is there or not. So that can be an additional investigation done post surgery or post biopsy report, like major specimen report, just
Dr.
as a
Abhishek, where they are doing this? 18 to
ma'am,
21.
it is doing they are doing in Kolkata. Is in ball
Okay.
there is a lab.
Huh.
It is a lab from Assam University. It is a sponsored lab. So
Okay.
presently they are doing it for very cheap. Like it is
Mm-hmm.
costing around 28, but if we are giving around on a routine basis, because that person who is doing that, he's not,
Mm-hmm.
he's also a professor from biotechnology. So
Mm-hmm.
I'm presently my topic is like I have spoken to you long back, ma'am, about this.
Mm-hmm.
It is on mitochondrial DNA mutation. So I am checking
Okay.
mitochondrial DNA copy numbers and all. So
Mm-hmm.
I am doing also a panel for this HPVs also. It is still
Mm-hmm.
in progress. So that
Mm.
time a discussion came that these hereditary gene panel is also done. So
Oh.
that lab is
Mm.
claiming if
Mm.
a person is having a definite mutation, but if
Mm.
there is not a definite that a particular pathways, it is not following that particular gene, then even
Mm.
if you have new matlab, if you are even having 25 or 28 years of tobacco practice also, like tobacco
Mm.
consumption practice, you will not get cancer. So
Correct.
it's like that.
Mm.
So like
Mm.
every individual is having that particular signature. So
Mm,
what we are telling that tobacco causes cancer. The
mm,
lab has got recently a DST project where they it
mm,
is a almost a 10 years project. They have recently
mhm,
got almost like 38 crores. So they
mhm,
will be proving that the tobacco does not cause cancer. It is the only the genetic gene changes that will
mhm.
cause that actually pushes the person or the individual for cancer formation, where the predisposing factor is the tobacco.
Yeah, yeah. That is the same
Yeah.
thing, even for arachnid tumors, like one why few people are susceptible for, transformation and all.
Yeah,
Same
ma'am.
thing, that methylation thing,
Exactly, ma'am.
because
Epigenetics.
in this, I think you just have a collaboration with even with this ADR people. They are also doing wonderful studies. One
Okay, okay,
is
ma'am.
breast. They have done, complete profiling, and they
Profiling.
have that, yeah, nano this, and this itself is installed. It is worth some crore this. So
Got it,
every
ma'am.
test, yeah, and whoever is suffering from breast cancer, they're subjected, the panel
Subject to
they
that
run it,
particular.
yeah.
Yeah, ma'am.
Yes,
NGS. I think, ma'am,
yes,
NGS.
NGS, yes,
Next
correct,
generation
correct.
sequencing.
Yes,
This
next
lab is
generation.
recently got that grant,
And
ma'am.
also for cervical
Uh,
and all, they do the HPV, the whole
HPV
typing.
profiling.
Yes, yes, profiling.
Yes,
So
ma'am.
separately they have that. And for lung, they're doing. Now they wanted me also to be part of this oral pre-mal
That's great,
OPFDs,
ma'am.
and yeah, yeah.
That's great, ma'am. That's great, ma'am. It's
Mm,
a
I'll get
big
in touch
field
with
to.
you. Yeah.
No, that is a good thing, and
Mm.
there are many commercial labs which also do. Because I'm
Yes, yes.
following this thing from past 10 years, since
Mm-hmm.
2016. The test used to be around 2.5 lakhs for a
Mm-hmm.
comprehensive panel. And if you go
Okay.
about the head and neck cancer, the epigenetics which we are talking, it costs
Mm-hmm.
around 55 to 70K. In that,
Mm-hmm.
TP53, Notch 1 gene, and all those are being done. So
Mm.
comprehensive now it costs around 1.5.
Okay. Mm.
And core diagnostics, MedGenome, Newberg
Mm-hmm.
Med
Diagnostics, these
Genome is
are the
doing.
ones they do.
Med
MedGenome is the
Genome
number
is.
one, yeah, because my
Yeah, yeah.
samples they go there. That's why. So just for
Okay,
the
okay, ma'am.
awareness of everyone, would like to
Mm-hmm.
highlight on. Dr. Abhishek Badranna sir want to say something, please, sir.
I think he just left.
Uh, no, he was there only.
He just left. It's showing in my message.
Okay, okay. Okay, what about any more questions? So anybody would like to add something?
I think Dr. Garima is more confused.
Hmm.
Some solutions are not simple.
Yeah.
Patient has to pay.
Hmm.
Yeah, that is there.
Smita,
So,
I have a small thing from Smita ma'am and ma'am.
Hmm.
Do the dental colleges have this DSIR registration like all dental colleges? Because means you are
Hmm.
in the academics since like many years,
Hmm.
and
No, it's not there.
because if DSIR is not there, we cannot approach
Hmm.
for DST funding.
Yes. That's why
And
I'm also having problem, because mine is a private college, and
yeah,
we
ma'am.
don't have, every time I have to, even the university funding also is difficult. The government also, Karnataka government also has such funds. They
Okay,
prefer for government, Kidwai and all this, major
got
cancer
it,
hospitals like
got it,
Shankara.
ma'am.
Uh, that's why I'm finding it very difficult, because
Yeah, ma'am.
the
Actually,
project
we
which
have
I'm
good
trying to work
resources.
out, yeah,
Yeah.
and my what to tell, PhD topic also was a HPV typing only.
Yeah, ma'am. Yeah, ma'am.
Mm, Now it is advanced, and they want to eradicate, cervical cancer
Yes, yes, ma'am.
completely.
They have already come up with these vaccines and all.
Yeah, yeah. Nano this and all. Nine
Yeah, ma'am.
this trains, it'll
Yes, ma'am.
stop. Yeah.
so uh,
It was very good
if,
actually, Dr. Bhuvan, very nice
yeah,
initiative, and
thank you so
Shalaja is a
much.
very nice. orator with very good scientific facts. Mm.
Yes.
Thank you,
Thank you so
Smita.
much, ma'am.
Mm.
So now I think, ma'am, you are there, so you are one of the senior stalwarts. So I think you should only present token of appreciation. Anyways, you
Mm.
were in the audience, so I would like
Mm.
you to
Mm.
do the honors.
Yeah, it's my proud privilege, Dr. Shailaja. We two are contemporaries. Actually, we have been, meeting often, very often, at
Yes.
various workshops, and I know about her thesis also.
Hmm.
Yeah, very nice compilation and very nicely put, Shailaja. Hmm. Keep
Thank
up
you,
your
Dr.
good
Smita.
work. Yeah, I
Thank
always
you.
see your posts also. Lot of, you work for the screening and all that treatment modalities also, I think, in your area.
Yes.
Yeah, active in IDA also. Nice to
Hmm.
see. Hmm. Very nicely put, very informative slides. Very nice. Mhm. Thank you.
Thank
Hmm.
you.
Okay.
Yes.
If everybody can put on their camera, we can have a picture. Yes.
Hmm.
Any more?
Just tell when to stop smiling.
No, no. I'm waiting for so that everyone can like put on their cameras. Okay. Thank you so much, everyone, for their time. One
Hmm.
more. Yes. Thank you so much, everyone, and stay tuned for the updates. And we'll be back next month with another stalwart